talk about the blocked tube scenarios. Now, obviously, before thinking about the scenarios, you should know when there's a high chance of tube getting blocked. If the tube has just been inserted by you and you know the adequate depth of the tube inserted, why would you even think of that the tube has got blocked? It is very rare if there's some foreign body or the tube has got kinked. That may be a different thing, but the tube getting blocked due to secretions is negligible. Now, the first scenario is when you have inserted the tube yourself, you know the adequate depth of insertion, you know that is bilateral air entry, the peak pressures are normal on the ventilator, the end tidal CO2 curve and the value is fine, the oxygen saturation is fine. So ultimately you know the baseline of the patient. Even if the chest is poor, you know what were the baseline values. Second thing that you should make a habit of is detach the ventilator, attach an ambu bag and ambu bag, press the ambu bag. If the compliance, this first baseline compliance of the ambu bag will help you later diagnose how much tube might have got blocked. If it is a complete blocked, you won't be able to press ambu bag at all. The second scenario, when you do not know when the tube was last suctioned, suppose the patient was shifted from ward to the operation theater on ambu or vein circuit, the person bringing has not checked on the bilateral air entry. So that time you have to take the patient inside OT, attach the monitors, especially the pulse oximetry, check for bilateral air entry, try to do the suctioning. If you do have time and there's some partial air entry, you can give 100% oxygen, do the suctioning comfortably. But if the tube is completely blocked, you attach the ambu bag and you are not able to press at all. In the air end, there is no air entry, or the saturation has already started dipping down. You don't have time. At that time, you have to do the laryngoscopy and replace the tube as such. The third scenario is if the patient is in ICU and you already have connected the patient to the ventilator and you do not know when the tube was last suctioned and what was the baseline. So increase in peak pressures or change in the end tidal CO2, you don't know what was the baseline, so you detach the ventilator from the patient. This is the fastest way to know whether the tube is blocked or not. You attach the ambu bag. So here comes the importance. If you are not able to press at all, that means either it is the tube has got kinked or it is completely blocked. You do a quick laryngoscopy. If the tube is not kinked anywhere, the only reason can be completely blocked tube. You have to remove the tube and replace it with a new one. If it is partially blocked, there is some air entry and you don't know the baseline peak pressures and end tidal CO2, you still have time. You can put NS, 3 to 4 ml of NS, give some positive pressure through the ambu and try to suction the tube. The thick purulent secretions will point towards that the tube can again get completely blocked.